So I have two questions, and if there's not time to answer both, you can skip one. My first question is, you identified the role of suffering, and I would say existential suffering, based on what I've read, is definitely, even doctors who are providing MAID are recognizing that. What would your comments be on maybe how we can insert meaning into the experience of someone who is suffering, but much earlier? I can see how you're doing it with patients when they're making that request, but how can we be proactive?
Oh, excellent question.
And then my second question is, there was a situation in my family where my grandmother's partner was starting to request medical aid in dying, and when he eventually changed his mind and tried to get that removed from his document, there was a lot of pushback from the nurses who identified him, I would say correctly, as not like a very pleasant individual, and so there seemed to be a lot of bias and there was a lot of misinformation, and so they did remove it, but only because my family didn't leave the hospital until they did. And so I'm just wondering if you can comment on the role. I think medical professionals are trying to make this sound like a very objective analysis, like you meet the criteria or you don't, but I get the sense that there's a lot of subjective projection of someone's personal beliefs as a physician into that. So could you comment on what that looks like?
Yeah, so both really good questions. In terms of the first, that's so critical, and the answer, of course, is relationship. So we have relationship with people early on, and in terms of palliative care medicine, what we're trying to do is bring palliative care medicine early on as well. And so, you have someone who's been diagnosed with a heart condition, rather than waiting till the very end, and then we get palliative care. Unless we get them involved with palliative care. No, we start right early, years earlier even. And so we have that opportunity to begin, talking about unpacking this stuff for some time. It's hard to know how much time we've got. And so the earlier we can get palliative care going, the better. And our relationship with people and speaking the fuller truth of who they are, our identity in Christ, even if they aren't Christian and don't understand what that would be, we know what it means. We know, where they find significance, how they feel accepted, where they feel secure. Those are the key kind of elements of our identity. We know them for ourselves, And if you can't answer Christ for those three things, then you got a bit of an identity issue too, And I certainly did. GPA was my identity, or more medicine was for a while too. So we can speak into that for in terms through a relationship. And the second question was more in terms of the bias. So. Tremendous bias. I mean, we have to be so careful. I can, with my white, I'm not trying to brag here, but with my white coat on, I go into a room, I could really convince someone of almost anything I want to. We talk about, making sure they have, all the information, they can make a wise decision, and we do want that for people. But we also know what's best for them as well, and how you present the information, how you do it. I'm not saying it's everything, but it's a huge role. I'm just being honest with you. That's why it puts incredible responsibility on the healthcare provider. And I'll have to I'll stand before the judge someday myself, and so you got to be careful with what you do. Not just Spider-Man. We're given a lot of responsibility, and so we do have a big influence in how we paint things and how we present things to people, how we have them understand things. And the people who are, the vulnerable people who are moving toward requesting this are so vulnerable in their minds. And if they think, for example, they're a burden, they're even a burden for me on the ward. They're a burden. If they feel that, and we can communicate that to them in so many, without even using words. And then it can help kind of push them along that way. If we want someone to die, we can actually encourage them down that path, Oh, you've had a good life, whatever. You know how it can be done. People are so vulnerable then. And so we have to be so careful, with them. And I think, like I said, there's so much opportunity then for us to have to speak into that stuff. Because they're really quite open. These people are really open. They're dying, and they're they're hurting and they're afraid and all these things, And so it's a tremendous opportunity that can be a very positive thing, can be used very positively, and can be used very negatively. So I think the doctor or the physician, the healthcare provider, has a tremendous role to play, and it can be a wonderful one or a horrible one. We got to be really careful about that, for sure.